Nope, it's not coming back. It's gone. Was there another question? Everyone's fiercely like crap. I go home, throw in a protein powder. And it stinks. All right, so we're going to start talking about the cardiovascular system. Okay, we're going to start talking about cardiovascular system. This is going to go in a lot of ways, just like what we did in the neuromuscular system, but I'm going to give you guys some anatomy and some basic phys that I hope is going to be relatively reviewed for you guys. Then we're going to get into some of the control things. And then Skillet and Christina will be like, this is nothing compared to what we're doing in the PhD level cardiovascular phys class. I know all of that. I'm just trying to get everybody to kind of a similar level. We do offer a kind of exclusively cardiovascular phys course. If you guys have any interest in taking and learning more about that, then you could talk to the ladies and see when Keller wants to keep taking. Probably it'll be 2 falls for them. But we're going to go through some structures. We're going to talk about some functions at rest and then how those functions are going to change during exercise. We'll talk about circulation. So kind of what's happening in blood vessels. Where is your blood? Where does it go during exercise? And then what are the control mechanisms that help us move all of this around? Okay. How do we get it where it's supposed to go and why? And then we'll talk at the very end about O2 transport and kind of the nature of how hemoglobin and the blood are used to kind of bind up O2. And so that when we put the circulation to a certain place, then we can basically get the oxygen. I'm sure Dr. Kellerwan or any other cardiovascular physiologist would not like for me to say this, but most of the changes that take place in the cardiovascular system occur in an effort to support other physiological systems. Okay? We need to support metabolism, very often metabolism in muscles. We need to move nutrients to certain tissues. Okay? We need to send blood to the intestines. We need to send blood to the liver and the kidneys in order to have that blood sort of filtered and cleaned and all of that. All right? Your brain needs a certain amount of blood because it needs glucose and it needs oxygen. So we're going to talk about this as a sort of supportive system that is going to respond to changes occurring in other systems. Okay. However, that's not to say that if you do not get the proper changes, if you do not have proper function in the cardiovascular system, that anything else is going to actually work. So it's an immensely important system. But I think it's important for me when I try to contextualize why do certain things change in the way that they do, that you appreciate that the signals that drive shifts in the cardiovascular system are very often going to arise in other systems. And if you can contextualize it in that way, then maybe it will make a little bit more sense about why certain changes happen. We'll try to be meaningful as we point those things out. And of course, none of this doesn't have to work because why not? What a day. Okay. So we talked about this. Of the things that we've talked about so far, remember muscles generate force, they help us move, they need energy. So we've got metabolism does all of this. Well, the cardiovascular system is going to provide us in a lot of ways the oxygen and the substrate, okay, that are going to let us exercise and let us perform. So because of all of that, proper changes in this system and the adaptations that take place in this system, right? We need the acute changes to let us do things now. And then you guys are going to see there's lots and lots of changes, especially with aerobic exercise that can occur in the cardiovascular system. It's very plastic. It can change, okay? And so all of those things are going to drive some of our longer term adaptations if you train, but also allow us to exercise. The other part that's really not a part of our class at all, but I think is really important because you're going to encounter this in your everyday life, is that this is the system that when it doesn't work right, kills us. Okay? Cardiovascular disease is the leading cause of death. Okay? Some of the changes that occur in the cardiovascular system due to being obese and being sedentary are very, very bad. They're very, very deleterious to our health. So improper function in this system and understanding how certain pathologies affect all of that are going to be really important. So if we know what normal function is, then we can hopefully, if I tell you that you have atherosclerosis, and therefore you're blocking the endothelial layer on your arteries and arterioles, therefore you cannot send blood where it needs to go properly during exercise or regulate blood pressure correctly, you will understand why that's going to be the case. Okay, so we'll bring some of that back a little bit later on in class. People that tend to study cardiovascular function study pathological function. Okay? What's wrong if somebody has high blood pressure? What's wrong if somebody has had a stroke or has atherosclerosis? Okay? Arguably, the single most widely prescribed drug, or two drugs really, Lipitor and Viagra, are going to affect the cardiovascular system. There's a lot of stuff going on. Okay, so you don't have to remember all of these different things, right? But it has a lot of different functions. We're going to deliver oxygen and nutrients. We've got to remove CO2 and other waste products, right? Those are going to often then get sort of shunted around, transported to other tissues. We use the cardiovascular system by definition to transport hormones, okay, which are going to control other functions. We're going to use some of this system to help us regulate body temperature and to regulate pH. We'll talk about this a little bit, okay? But again, we can do a whole class just talking about the effects of body temperature regulation, the physiology of that, the pathology of that, how exercise in the heat alters those things, how fluid replacement affects all of this. There's some really cool kind of performance physiology related to all of these things. And then we don't talk about it very much at all as it relates to exercise, but the cardiovascular system also plays a huge role in helping us to control infection and function. Okay? At least the cardiovascular system, in addition to kind of like your lymph tissue, is a way that we can move blood and white blood cells especially around. Okay? COVID binds to a angiotensin converting receptor. So, which is a thing that's going to play a big role in the cardiovascular system. So, some interesting stuff there. Three primary components or kind of tissues that I want you all to know. They're going to be here. We're going to take each of these. Okay. So, that's the heart, that's blood vessels, and that's blood. Most of you guys have probably learned quite a bit about the heart and about blood vessels. Hopefully, we'll get you guys a little bit of additional information on how all of this works. Above and beyond what you've already seen. But I think blood is maybe one that I know at the undergraduate level here that our teachers don't spend a lot of time talking about the importance of blood. And I think blood is really, of all of these things, kind of the most under discussed, but maybe you can argue is the most important, because this is where the hemoglobin is, this is where all the oxygen is, this is where all the hormones, the nutrients, and things are all in the blood. And there's some very special characteristics about blood that allow all of that to happen. And so I think it's really important that we understand some things about red blood cells and plasma volume and some things like that. Okay, so we'll take all of these in turn. We'll start off by talking about the heart. So that's probably what we're doing today, is mostly just kind of heart-related things. Then we'll get into blood vessels and blood stuff. Okay, yay, here's the heart. Everybody, take your left hand, put it out, make your fist, put it out in front of you like so. Don't laugh at me, Gabe. Do this, point it so that kind of this angle is sort of angling at your left hip. Put it right here, just to the left of center in your chest. There's your heart. That's its orientation. That's approximately its size. For most of you, your heart's about the size of your fist. Okay. There's your heart. So when you're looking at this, for those of you that either have or haven't, everybody had anatomy? Yeah, everybody had anatomy? High school? Okay. My biomedical engineer, sir, you have anatomy? No. Yes. Okay. I'm not the only one in class that hasn't had anatomy. You're fine. Right? I have a PhD in ex-phys. I've never had anatomy. It's okay. All right. This is the heart. We're looking into the thing. So this is actually the left side. This is actually the right side. All right. All I want you to know from an anatomical standpoint is, can you please know the four chambers? Okay. Things on the top are, who remembers? What are these? Atria. And then what are these on the bottom? Ventricles. Very good. So this side over here, this is the right side, this is the left side. We have a right atria and a right ventricle. We have a left atria and a left ventricle. I want you to know the 4 chambers. I want you to know that blood from what I'm calling systemic circulation. So all blood from your veins coming back into the heart are going to come in through the superior vena cava, right? It's going to come in and go into the right atria. It then moves into the right ventricle and it gets ejected out and it goes to the lungs. So right side of the heart blood has relatively lower oxygen content, relatively higher CO2 content. It goes to the lungs, pick up oxygen, we let go of CO2. It comes back to the heart in the left atria, high O2, low CO2, into the left ventricle contracts, blood leaves out through the aorta, or off into systemic circulation. That's all that I need you to know, okay? If only because we're going to talk about things called venous return, so blood coming back in over here. And we're going to talk about stroke volume and heart rate, which are going to really be things that are measured from what's happening in the left. All you got to know. I don't care if you know about the valves. I don't care if you know how many flaps the valves have. You have to know any of the other arteries. None of that. Okay. They are important things, but you can go get an anatomy book and look them up. Questions? Problems? Anyone else sweating in here today because you overdressed thinking it was going to be like -40 again? We complained last week, so they came somehow and tried to fix what's going on, but now it's hot. I feel like I'm sweating. Okay. So cardiac muscle is muscle just like skeletal muscle. Okay. For the most part, it looks just like skeletal muscle. It's striated. It's very organized. It has a pattern of actin and myosin organized in sarcomeres, just like skeletal muscle. It only has a few central nuclei, just like skeletal muscle. However, it's a little bit different than skeletal muscle. All right? I guess I should back up and say, think of your heart as a muscle because your heart is a muscle, right? Its one job is to contract, just like skeletal muscle. It uses energy to contract, right? So it looks like this, but what separates the heart from skeletal muscle is it has a more extensive capillary network, and about 40%, which is a huge amount of its cytoplasmic volume is mitochondria. Okay? Whereas in skeletal muscle, it's maybe 5%. 40%. So maybe 7 or 8 times or 9 times as much of the cellular volume is occupied by mitochondria. So if it has a bunch of mitochondria, what would it be really good at, Josiah? Do you think? Very good. Your heart is really good at using oxygen to make ATP and make sure that it doesn't make lactic acid. When you have a heart attack and you have angina pain and things, guess what that's from? Lactic acid. Okay. So we have lots of capillaries to bring oxygen. And the heart is very, very vascular. We're going to bring lots of oxygen to that muscle. We've got lots of mitochondria to use that oxygen to help us make ATP. Right? Think about this. Pick some other number. Brady, how old are you? 23. Okay. Brady's heart has been beating for 23 years and 7 months, or not even 7, probably more like 8.5 or something. Now veered into Texas abortion law and heartbeats, and when they develop, and when they want to be there. Brady's heart's been beating for a long time, right? Let's say 23 years. 70 beats per minute. How many minutes are there in a day? Anybody know? Something like that. We've now become a song from Rent. You guys have seen Rent? Anybody know Rent? Seconds. There's a famous sort of Broadway musical. It's called Rent. There's a song in Rent. Yeah. It's like 555,600. Anyway, we can calculate how many times Brady's heart has beat since he's, been here with us. Okay? Beats about every second. Do you ever think about it? No. Right? One time you think about when your heart beating is when it's not beating. All of that. Okay? Is your heart tired, Brady? Sure? Okay. I don't mean like emotionally is your heart tired. I mean like physically is your heart tired, right? So we love the Big Bang Theory. Am I like the Big Bang Theory? We were watching the Big Bang Theory the other night, and it was an episode where, if anybody knows the things, the Penny's character, and then there is Sheldon's girlfriend, Amy Farrah Fowler, and she says, Penny was fine until Leonard punched her in the heart. And it always just cracks me up. Anyway, you imagine if you'd been doing squats 1 time a second since you were born, basically. 1 squat a second, probably even more than that, since you've been born. Can you imagine how tired your legs would be? You would have huge legs, right? But you'd also be very tired. But because of this, your cardiac muscle is not tired. Okay? That was my point behind all of those kinds of things. Now, cardiac muscle has a few other, this is not all of them, but it's a few of the kind of more important ones. Specialized structures are going to help hold each of the individual fibers together. Because of the way that cardiac muscle gets told to depolarize, it is different than how skeletal muscle gets told to depolarize. Cardiac muscle does not have a neuromuscular junction. Okay? So we're going to end up spreading activity from some nerves onto the individual fibers, but then a lot of this transmission goes from one cardiac muscle cell to the next. So we need these cells to be held together very tightly. So where one cell kind of comes into close contact with another is called an intercalated disc. At that intercalated disc are these things called desmosomes. Desmosomes are basically like clamps, right? Just grabs onto the thing next to it and holds it there, and it holds it in position really tightly. And then you also have what are basically pores. They're called gap junctions that are going to be holes that are going to allow for the rapid transmission from one fiber to the next. Okay? So these are some specialized structures. Skeletal muscle generally does not have these things. Cardiac muscle does. And again, here's where structure is going to help impart function in the way that these things are going to be told or to depolarize and contract. It's a little bit different. Okay. Here you can see kind of what some of these things look like. Here is cardiac muscle under a microscope. See, it looks stripy. Actin, myosin, sarcomeres, just like in skeletal muscle. Here you can see the nuclei on all of those things. But if you were to zoom down kind of right here where they're going to make close contact with each other, it looks like this. You have this big high surface area, right? You've got all of these kind of indentations and things that are going to be on there. They're going to provide lots of surface area for transmission, lots of surface area for us to be able to latch on to kind of one another. Okay. There's going to be these gap junctions that are going to occur. So this is the intercalated disc. So the desmosomes are going to be here. You see them kind of here when they're holding stuff together. And then these purple structures, these are the gap junctions to let stuff pass from them together. All right. So we've already established, we think, right? Brady, not a vampire. Heart is beating, right? But he's not doing it. Okay? Skillet, change your heart rate right now. I'm serious. Make your heart rate, I don't know, make it stop. Can you do it?
Giving it stop, like it's slowed down.
How can you slow it down?
I stay really still, breathe less.
Not talk in class, not have me call attention to you in class and those kinds of things?
Yeah.
Okay. You want to pick someone, we're going to make their heart rate speed up. Singer, are you a singer?
Heck no.
Perfect.
Nope, I'm not.
You guys want Christine to stand up on the chair and sing us a song?
Tell us about the milk and chocolate. The milk 5K.
Oh, what?
The milk 5K or something like this. The beer 5K.
No. Okay. It's okay. Nope. We're okay. I think I've made my point, right? I've altered your heart rate, but you have no control over it. That's the part that makes cardiac muscle so interesting in some ways and so different than skeletal muscle. There is no voluntary control. Okay? If you want to make your heart rate go up, you got to either take something, meth, cocaine, make it go up. Maybe caffeine normally makes it go up when you exercise, and rest, it doesn't do a whole lot. Or you have to stress yourself out. So I can tell all of you guys, oh, we're about to have a pop quiz. Heart rates immediately go up. Okay? Or we could say, Drew, you're about to have to do jumping jacks. Before he even gets to stand up, his heart rate's already gone up. It's an anticipatory increase due to the sympathetic nervous system. So the way that we control cardiac contractions is through something called the cardiac conduction system. Okay? You're going to get a synchronous contraction, we hope, of your heart, where once basically one chamber is going to get depolarized, all of the other three chambers are also going to get depolarized. If that doesn't happen, call 911. Okay? We got problems. Okay? The other issue is that because of the cardiac conduction system, we have cells in cardiac muscle as well as some nervous tissue that have what we call intrinsic rhythmicity. And what this means is that these cells have leaky sodium channels. So they're going to leak sodium in, which means they're constantly being dragged ever so slowly towards a threshold potential that will lead to the generation of an action potential. Okay, so if we do nothing to your cardiac muscle, it will about 80 times or 70, 80 times a minute, it will spontaneously polarize and you will get a contraction. That is called intrinsic rhythmicity. We don't need an external signal. We don't need an external stimulus. Okay, now we can apply external signals to this intrinsic rhythmicity and alter the rate at which this is occurring. We'll get to that in a minute. Okay. So other people will call intrinsic rhythmicity autoconduction. And what that means is just that it's going to spontaneously polarize. And we'll go through the tissues where this should ideally be driven from in just a couple of minutes. Okay. In an average person, it's going to vary across all of you guys, but in an average person, given no external input of any kind, your intrinsic firing rate or intrinsic contraction rate in the heart is about 72 to 75 beats per minute. Okay? So you're just going to lay there, you're going to do anything, and that's what your heart rate's going. My guess is that none of you in here have that as your actual heart rate. So what's going to happen is we are able to apply some external signals, either from the parasympathetic nervous system or the sympathetic nervous system, on top of this autoconduction, and it will alter what is happening here. Okay? Additionally, the ability or our ability to change this rate is going to become really, really important for our ability to increase cardiac output during exercise. So I can give people drugs that will like blunt this increase. It absolutely knocks back your ability to exercise. You're kind of in exercise capacity. So we'll talk about that. Okay. Everybody with me? Hopefully all of this you guys have seen. So let's talk about the cardiac conduction system. Let's talk about the SA node, the AV node, the AV bundle, or the bundle of HES, even though it's spelled HIS, and then Purkinje fibers. Okay. There are 4 components of the cardiac conduction system, not counting the actual cardiac muscle. These 4 things are either collection of like nerves or they are actual nerves themselves. Okay. Generally, the initiation of a cardiac contraction is going to occur right here in the outer wall on the top of the right atria called the sinoatrial node or the SA node. Okay. If you've ever had an EKG done, if you ever watch any medical shows or anything else, people will talk about what they call sinus rhythm or normal sinus rhythm. What that means is that the heart is getting some sort of quote unquote normal pattern of contractions that are being initiated from the SA node. The SA node depolarizes, it spreads across the atria. Those atria will contract. It will then reach what we call the AV node, or the atrioventricular node, which is in the wall between the right atria and the right ventricle. That will depolarize. And then it moves down the septum, or the middle part of the heart, down what we call the bundle of HES, into these what we call Purkinje fibers that are going to turn and then wrap themselves back around everything. Okay. Now, the ends of the Purkinje fiber are the closest thing to a neuromuscular junction that we have in the heart. Okay. As these things depolarize, they're going to then depolarize the adjacent cardiac muscle. So it starts in the atria, so the atria depolarize first. Boom, they contract. When they contract, they squirt the blood that is in them into the ventricles. Okay? We then jump down the septum, we reach the bottom, and then the ventricles are going to tend to depolarize from the bottom up, which is good because blood that leaves them is going to leave out the top. And so the heart contracts, they twist on each other. It's like twisting this way. Okay? And as it twists, it's going to, like wringing water out of a wet towel, it's going to go from the bottom and sort of twist itself up and wring the blood and push the blood out through the pulmonary arteries or out through the aorta. So this is a situation where having these nerve fibers allow for faster conduction, then the signal can move along just the surface of the heart. So it moves us from atria down to the bottom and then the bottom of the ventricles up. Okay. If we don't have normal sinus rhythm, if this is not the point of initiation, you can get spontaneous contractions from the ventricles or from the AV node or something. If that happens, then you may begin to throw the pattern of atria ventricles off. And if that happens, we need to get the paddles out and try to shock you back to normal. Because blood's not going to move around in the proper way it's supposed to. That's kind of where we are. Okay. All of this makes sense. Okay. You have to build on all of this because we're just going to assume that we get all of this and talk about things that happen during exercise. They're going to be driven by kind of what's going on here. Okay. So we call one heartbeat, we generally refer to that as a cardiac cycle. Okay. In a cardiac cycle, you're going to have each atria and each ventricle contract once. Okay. In that cardiac cycle, before each of them contracts, there's going to be a period of time while they are relaxed that they are going to fill with blood. So the time when they're filling in the cardiac cycle is referred to as diastole. And then when they contract, that is referred to as systole. So in one cardiac cycle, all four chambers of the heart are going to have a period of filling of diastole and a period of systole when they are actively contracting. And those tend to be sort of opposed to each other. While the atria are in systole, the ventricles are in diastole. While the ventricles are in systole, the atria are in diastole. It's just alternating filling, contract, filling, contract. That doesn't happen, bad things are going to go. Okay? In a normal person with a resting heart rate with nothing on of about 72 to 75 beats per minute, your chambers are going to spend roughly 60% of their time in diastole. More time in diastole and about 40% time in systole. This will become really important when we start talking about high intensity exercise and the heart rate or the number of cardiac cycles per minute is really, really high. Because what happens is that the period of time, both in an absolute and a relative sense of the cardiac cycle that we spend in diastole is going to shrink. At some point, filling time can become so small that it's going to potentially limit the amount of blood that can get in there. And that's going to have some limitations on stroke volume and cardiac output. So we need to pay attention. Okay, so that's kind of how this is all going to go. So here's a representation I like of what this is. So what you can see here is one cardiac cycle. Here we have a person who has a resting heart rate of 75 beats per minute. And you can see that means that they get a contraction about every 0.8 seconds. Of that 0.8 second contraction or cardiac cycle, about a third of a second is in systole and about half of a second is spin. So now let's take that same person and let's move them to they're running very, very vigorously. They have a heart rate of 180 beats per minute. So the amount of time, the total amount of time has now shrunk. So a cardiac cycle is about a third of a second. And now systole is going to be longer than diastole. So systole is about 0.2 of a second and diastole is about 1/10 of a second. So the whole thing has gotten smaller. And you can see that systole now predominates. So look at this big dip in the actual amount of time that we spend in diastole is going to be. And so we need to be able to fill, and you guys will talk a lot about on Wednesday on the necessity of what happens during diastole and its control on stroke volume. And this is going to become a really, really potential kind of pinch point in controlling exercise, okay? Or controlling, kind of blocking off VO2 max and some things here. All right. If I show you an EKG, you're going to freak out. Okay. Anybody ever had to like actually read an EKG in real life, like anything Christina has, Josiah, you have? Okay. Good for you guys. Pretty hard, isn't it?
Yeah.
Okay. For your internship, we probably shouldn't have had you do it.
Well,
We
it's
won't.
a cardiac nurse.
Okay. We won't do these in my lab because we can't track well enough if there's a problem and you're liable to the IRB if you've got an EKG hooked up and somebody throws S&T segment compression or something. You're like, oh, we missed it. They're about to have a heart attack. So we cover our butt by not doing them. But all I want you to know about this is just the kind of very general sense. This is an EKG, right? It's a measure of the electrical activity in the heart. So we can measure when the atria are depolarizing, when the ventricles are depolarizing, and we can use all of this very distinct rhythmic pattern of things to learn some information about cardiac function. Okay, this is one of the gold standard tests. You have a heart attack, or you think you've had a heart attack. Once to make sure you're not going to die, you go to the hospital, you put your ass on a treadmill, hook you up to the EKG, and say, go. Try to recreate the whole process. Because we can use this to diagnose where potentially in the heart is there going to be a problem. You don't have to do that for this class. I'm not going to show you guys. You're not going to have to see pathological EKGs or anything else. But you see this P wave here, what's called a P wave at the very beginning. This represents the depolarization of the atria. That's followed by a QRS complex, which is going to really denote ventricular firing or ventricular depolarization. Atrial repolarization occurs. It's kind of hidden underneath all of this. And there will be some sort of a short break, and then the ventricles will depolarize. So you basically have atrial systole, atrial diastole is here, ventricular systole, and then ventricular diastole is going to be back here. You get into the T. Okay. When you want to measure heart rate, you measure from the peak of one R to the next. You have some known amount of time. You count your R wave, your heart rate, if you want to do those kinds of things. And then look at kind of how all those other segments are going to progress to really diagnose things. You see the P wave and the QRS every time or not. This segment right here, from S to T, this little piece right here, this ventricular repolarization segment is especially sensitive to ventricular ischemia or a lack of blood flow there. You can get some very distinct and kind of recognizable changes. It's called S&T segment depression that can occur here, which means the person is probably either having or about to have a heart attack. It's going to go on right there. All right, this just kind of shows the events. I love this graph even though you guys don't have to know it. Okay? I love a graph because it shows sort of pressure in the left ventricle, volume of blood in the left ventricle, and it sort of shows all of that put over the top of what is happening systole, diastole, what do the sounds in the heart look like, what's the electrical activity doing, what's happening to left ventricular sort of blood volume, atrial pressure, ventricular pressure, aortic pressure, and the opening and closing of all the valves. It kind of lays all of this on the top of each other. Okay. But again, it's just going to show us that we get some electrical signal that initiates a contraction. That contraction is then going to drive a change in blood volume in a particular place, which is going to drive a change in pressure. Really, the change in pressure drives the change in volume. And then, so you guys don't have to know this. I just think it's a really nice graph and a really nice way to kind of lay it. Okay, we're going to stop here for today. Okay, I don't want to get into stroke volume and heart rate because there's so much we need to talk about from a regulatory standpoint. So we'll pick up with this on Wednesday. We will have a quiz on Wednesday. I apologize that I did not get the notes and everything posted until this morning. That's on me. They're up now, so we'll have a quiz on Wednesday. Okay. Your test corrections, if you choose to do them, are due Friday. Sweet.